Thank you for joining us. We'll begin the webinar in just a minute. Good afternoon on the East Coast. Good morning, other parts of the country. Thanks for joining us for today's telebriefing. My name is Rhea Farberman. I'm the Director of Strategic Communications and Policy Research at Trust for America's Health, also known as TFAH, TFAH. During today's briefing, we're going to be sharing with you the findings and recommendations of a new report being released tomorrow, Public Health Infrastructure in Crisis. This report comes at a particularly important time for the public health infrastructure and our nation's public health, so I appreciate your interest. During today's briefing, we're going to hear from 3 public health experts, and then we'll have time, I'd say 20 to 25 minutes for your questions. If you haven't submitted a question as of yet, you're welcome to do so. Just use the Q&A tool and share with us your question, your name, and your media outlet. We'll get to as many questions as we can. It's my pleasure to introduce our first speaker. Our first panelist will be Dr. J. Nadine Gracia. She is the President and CEO of Trust for America's Health. Dr. Gracia is a national leader in the area of public health and health policy. During the Obama administration, she served as the Deputy Assistant Secretary for Minority Health and was the Director of the Office of Minority Health at HHS. Dr. Gracia, please.
Thank you, Rhea, and I want to thank my co-panelists as well as to all of you from the media who are joining for today's briefing. For those of you that are not familiar with Trust for America's Health, commonly known as TFAH, we are a nonpartisan, nonprofit public health policy, research, and advocacy organization, and we work to advance evidence-based policies to promote the health and well-being of every person and community. For over 2 decades, TFAH has authored an annual report tracking public health funding. And for this year's report, we took a different approach due to the scale, scope, and potential impacts of the federal actions and proposed actions affecting the public health system, including funding cuts, staff layoffs, funding clawbacks, and agency reorganizations. This year's report is focused on HHS, particularly CDC, due to the central role that it plays in national and global public health and as a major source of funding and technical support for state, local, tribal, and territorial health departments. We tallied and analyzed the current and proposed cuts, agency reorganizations, and workforce reductions, and the impacts that they will have on the nation's health and economic security. Next slide, please. So to share with you key findings in the report, here's what we found. The President's fiscal year 2026 budget request includes a 53% reduction to CDC's funding. Overall, the proposed budget cuts CDC and the Agency for Toxic Substances and Disease Registry, or ATSDR, funding by slightly more than half, and then would move about 26% of the lost funding to 2 newly proposed HHS divisions, the Administration for a Healthy America and the Office of Strategy. But the structure and capacities of these new entities are unknown at this point. The proposed restructuring of HHS agencies would reduce the number of staff positions working across the department by 16%, even when accounting for the creation of a new Administration for a Healthy America. Within CDC cuts, there's a proposed 52% reduction in funding for the Public Health Emergency Preparedness Program. This is a program that's the primary source of federal funding for state and local emergency preparedness. These cuts would make communities across the country less prepared for outbreaks, as well as natural disasters such as hurricanes, floods, wildfires, and heat waves, at a time when the frequency and intensity of such events are increasing. In addition to significantly less funding, the loss of expertise from CDC and other HHS agencies is already having an impact on health responses across the country. state and local health departments work with CDC experts, scientists, and laboratories during outbreaks and other emerging threats. The workforce reductions mean that states and localities may not be able to rely on federal expertise and on-the-ground support during emergencies and as they work to address ongoing health challenges. The workforce for entire divisions at CDC has already been eliminated, such as all staff working on smoking cessation, drowning prevention, and tribal health. Next slide, please. Now, these changes would have truly a detrimental effect on communities and Americans' health. It's important to note that 80% of CDC's domestic budget goes to states, localities, territories, tribes, and tribal organizations, and other partners. So cuts to federal funding are cuts to state and local public health budgets. And we're already seeing how cuts to federal funding impact public health across the country. This year's termination of previously approved funds clawed back over $12 billion in COVID-19 era grants, funding that, in addition to supporting the pandemic response, was intended to strengthen public health infrastructure beyond the needs created by the pandemic, including infectious disease monitoring, laboratory capacity, emergency preparedness, and mental health services. Due to these clawbacks and delays in CDC receiving fiscal year 2025 money, health departments are having to make very difficult decisions, laying off staff, cutting programs that safeguard health, such as smoking cessation, maternal and infant health, mental health and substance use, and vaccine access programs. And my fellow panelists will speak more about these cuts. These cuts and changes will lead to widening health disparities. Rural areas, other communities that are under-resourced, communities with low incomes, and certain communities of color will face the biggest setbacks. In the report, we interviewed state and local health officials who are on the front lines of promoting and protecting the health of their communities about how they're navigating these funding cuts. Their budgets will likely be further reduced if the president's proposed budget is passed. Their perspectives highlight the on-the-ground impact in their communities. Next slide, please. Now, if the president's fiscal year 2026 budget request is adopted, over 100 public health programs and funding lines would be eliminated at 2 agencies within HHS, 61 at CDC and 40 at the Substance Abuse and Mental Health Services Administration, or SAMHSA. These include programs focused on cancer, diabetes, heart disease, and stroke prevention programs, obesity prevention, global and domestic HIV/AIDS prevention, global immunization, and substance use prevention and recovery. There would be additional eliminations at other HHS agencies. Next slide, please. So why does all this matter? Well, it matters because the risks to our nation's health security are real and increasing, including infectious disease outbreaks, rising rates of chronic diseases, a mental health and substance use crisis, and increasing frequency and intensity of extreme weather events. Because spending on public health is an investment in safeguarding the nation's health and supporting a strong economy. And because spending on public health has a strong return on investment in terms of reduced healthcare spending, better health outcomes, and increased economic productivity. Next slide, please. And it's important to ask then, what is at risk? Well, the long-term impacts of such significant changes to public health funding and workforce capacity would likely include increased healthcare spending and strain on the nation's healthcare system as prevention programs are lost, impacts on the nation's labor force, including more absence due to illness and disability, which are a cost and burden for both workers and employers. The concern of reduced life expectancy, a sobering possibility given that the US already has the lowest life expectancy among high-income nations, and reduced emergency readiness and response capacity at a time when health threats are increasing. Next slide, please. So our report includes recommendations for Congress and the administration to modernize and strengthen the public health system. Some of our recommendations to Congress and the administration include to reverse the 2025 cuts to workforce and funding and work to rebuild lost expertise and capacity, to ensure that we are strengthening the capabilities and distinct functions of federal health agencies, including CDC, HRSA, SAMHSA, the Administration for Strategic Preparedness and Response, the Administration for Community Living, and other agencies. These agencies have specific, complementary, and distinct roles and expertise in protecting the nation's health. Additional recommendations include Congress, in collaboration with federal agencies and partners, should be leading up a bipartisan deliberative process for reviewing proposed federal health agency restructuring, and that we should strengthen CDC as a national comprehensive public health agency and provide stable, predictable funding for its work. Federal agencies should also spend all funds appropriated by Congress, stopping the delays, the freezes, and impoundments, which leaves communities at risk, can weaken our economy, and disrupt research. And finally, to invest in the nation's public health infrastructure, supporting our workforce, the labs, and the data modernization for 21st century health threats. Now, before we hear from my colleagues, I want to emphasize that this report is meant to document the recent and proposed actions and changes affecting the nation's public health system and to support informed decision-making by policymakers and public health officials as they work to ensure Americans' health, safety, and security. It documents what has already happened, what is being proposed, and the serious consequences that these actions can pose for our nation's health and security. And the importance of these issues truly can't be overstated. I'll turn it now back to my colleague, Rhea Farberman, to introduce our panelists. Thank you, Rhea.
Thank you, Dr. Gracia. Next panelist is Dr. Joseph Cantor. Dr. Cantor is the CEO of the Association of State and Territorial Health Officials. Dr. Cantor, the floor is yours.
Thanks so much, Rhea. And my sincerest thanks to Dr. Gracia and the entire team at Trust for America's Health, as well as Lori Freeman and the team at NACCHO as well. I'm fortunate to have such really wonderful colleagues in this space. I have the pleasure of serving as the CEO of ASTO. We support the work of health departments in states and territories across the country. I want to first start by saying this is a very thorough report. I deeply appreciate the work of the TFAH team in putting this together, and I am alarmed by the findings. The reductions and instability in public health funding highlighted in this report are deeply troubling, and I think warrant further examination of the potential effects on the health of communities across the country. I agree with the recommendations enclosed within this report. I am deeply concerned about the potential for weakened public health infrastructure, both as a result of reductions in funding and instability and uncertainty in funding. I will say first, it is not just about funding for the CDC's functions, although those are extremely important and vital to the nation's health. What is not always appreciated, but is covered in this report, is the majority of funding that goes to the CDC goes out to communities and health departments throughout the country. About 80% of every dollar that goes into the CDC ends up going out to support really important public health work that's happening in communities across the country. I am deeply concerned about the threats to that type of work. The reality of the public health system in this country is that it's less of a cohesive top-down system and more of a collection of various systems. Cities, counties, states, their health departments comprise a mosaic of public health infrastructure that that supports people's wellness and health. It's decentralized. All of that work is tied to the CDC. The majority of it is funded by the CDC. And although folks might not realize it, crucial work happening in their communities every day is tied directly, in all likelihood, to the funding that we are talking about that has been put in jeopardy, and we worry about the stability going forwards. Take your average state health department. Your average state health department could easily be comprised of 60 or 70 or even 80% of federal funding. And this supports programs that are crucial to every individual's health in every community across the country, whether they know it or not. One of the realities of public health work is it's often invisible. It's often in the background. And many times when it's working really well, nobody knows about it. A couple examples of this are controlling the spread of tuberculosis outbreaks in a community, foodborne outbreaks that could threaten a restaurant chain or grocery store or food that ends up in people's kitchens, doing the hard work on the back end to identify and contain contaminated food before it grows and puts more families at risk. Hospital safety, working with health departments and hospitals to make sure that hospitals remain safe and free of very dangerous pathogens and a safe place for people to receive care. These are just three examples of many of the type of work that is happening every day in the background in communities across the country that are vital to people's ability to lead healthy lives, and ultimately is funded and supported by the CDC in ways that are not always obvious. In addition to the funding that CDC supports, CDC provides invaluable technical assistance and expert guidance to public health activities across the country. And I'm speaking to you now as a former local health director in New Orleans and a former state health director in Louisiana. I can name many, many outbreaks and other public health threats that I lack the capacity to fully respond to or the experts needed on my own within my agency, and relied on the CDC for expert opinions. Again, these are things that the public would likely never know about. But in the background, responses to complex health threats, on one hand, are always local because they're always happening in a community somewhere. But on the other hand, usually are buttressed by the expertise that's housed within the CDC. We cannot lose this. This is crucial to the health of every person in every community across this country, whether they realize it or not. But this type of work happens in the background. It happens every day, and it's so important to our ability to lead a healthy life. I'll also say this: prevention is a smart investment. A dollar spent in prevention or supporting preventative work usually pays dividends in many, many ways. And our acute care system, our hospital system in the country, is stretched rather thin. We need prevention to work well because the acute care system cannot withstand a large increase in sick patients across the country. Any threats to the preventative network within the country and preventative public health work, I fear will cause increase in disease and ultimately more patients requiring hospital care. And that's something that I don't think the country is fully prepared to withstand right now. Let me wrap up by saying a couple of things. One, although the bulk of public health work happens in the background, is non-politicized, is widely appreciated when people know about it, that type of work is put at jeopardy when funding is not stable and predictable. These are really, really important issues we're talking about. People's lives are on the line. And so I encourage all who deal with this type of funding to be methodical and thoughtful in their approach. I do want to mention there is some good news, at least in my mind. I want to let people know that in health agencies at the federal level and the state level and the local level, there remain thousands and thousands of deeply committed public health professionals who show up every day with one singular goal: to help make other people's lives better. And I'm deeply appreciative to them, and I want to lift them up and recognize them. And I've also been encouraged by recent discussions in the Senate, which have reflected a bipartisan support for stabilized public health funding, and I hope those efforts prevail. Rhea, I'll pass it back to you.
Thank you, Dr. Cantor. Our next panelist is Lori Freeman. Lori is the CEO of the National Association of County and City Health Officials. Lori, please.
Good afternoon, everybody. It's a pleasure to be with you all today. First of all, thank you to Nadine and to the Trust for America's Health team for this really important and critical and timely report. And also big thanks to our critical partner, ASTO, and to Joe Cantor. I so appreciate you all, and I'm very grateful for being in the space with you all in a difficult time like this. Every year, the TFAH report really helps to cast a really important light on the state of public health funding for the field and of our nation's investments in public health. With this year's report, which chronicles really significant changes to federal investments in public health and the impacts that those have had on work in communities every day across this country, it's really important not just to understand what happened to governmental public health over the course of this year, but also the implications of those changes to the health security of our country as a whole. Local health departments are on the front lines of the nation's health security 24 hours a day, 7 days a week, 365 days a year. The people that make up local health department workforces are in and of the communities that they serve. So they have a vested interest in good outcomes for their community and the people that live in them. Local health departments use the strength of the public health system partnership with our government's federal investments to really provide those services to individuals and families, protect schools, and prevent costly emergencies, and to stop disease outbreaks in their tracks. The health departments are really uniquely positioned to address the needs of every community. They're able to leverage close partnerships on the ground differently and use data to help to identify the problems right down to the neighborhood level and to offer solutions that are locally tailored and really positioned to work in that community. County and city health departments work each day to make their regions healthier and more resilient even before a crisis. They reduce the costly impact of chronic disease like heart disease and cancer and diabetes, and prepare for, and respond to infectious disease outbreaks like the measles outbreak that we had this year and many others. Protect our children from environmental hazards such as lead in drinking water in homes and poor air quality and in their environments. Address the ongoing opioid epidemic, and really provide maternal and child health services, including administering WIC programs on the ground in communities. Across all these activities, they utilize data to make sure that public health and healthcare activities in their community are effective and efficient, really as seamless as possible and focused on the people that need it most because their outcomes are often the worst. These local leaders work to address unique challenges facing their community to improve the quality of life and ensure economic productivity, while also helping to achieve national health priorities that improve our country's outcomes. The federal funds and the crucial public health partnership that we hold with our government are really important investment in that work. Federal dollars help them to do what we do best, protect our community through prevention and early intervention with targeted and efficient solutions that strengthen the health and resilience of our country as a whole. Traditionally, the nation spends pennies to the dollar on public health when compared to overall health investments each year. 90% of the nation's $4.9 trillion in spending in annual health care expenditures are for people who have chronic and mental health conditions. Our country's county and city health departments perform the exact interventions to prevent and manage these diseases that have such significant health and economic benefits for a tiny fraction of the 4.4 trillion spent caring for the sick after the fact. And in recent years, the federal government under both parties have really tried to ensure better investments in local public health. In fact, about 80% of the CDC's budget goes right out the door to support local and state health departments, where they are. These funds support our nation's public health capacity, and they promote chronic disease prevention from the ground up in communities. They build up systems that improve people's health at each day, and they ensure that we are better prepared to respond to emergencies when and not just if they occur. But as the TFAH report lays out well, over the last 9 months, there have been significant changes to the nation's investments impacting public health overall, and this has significantly squeezed local public health capacity. Each of the chronological changes that are spelled out in the TFAH report has contributed to a sense of confusion and concern, overall uncertainty around both current and future federal investments in public health programs, and has really brought the very question of the federal partnership role in governmental public health moving forward to a fine point. Remember, if it's a system of federal, state, and local resources and partnerships that is the foundation of our governmental public health system in our country, then any one part of those portions of the system that isn't functioning in the way it has in the past, or it's very different, can really impact and bring down the whole system. The changes that have occurred in our funding and structural stability makes it really incredibly difficult to conduct work on the ground for our counties and cities. For example, in March 2025, health departments were sent clawback notices of $11.4 billion in funding, essentially requiring them to stop public health programs and projects on a dime, to shut down services active in their community, and to let go and fire staff immediately. These pandemic funds were actively used to support recovery from the pandemic, to rebuild public health, to better position us as a nation to actually withstand the next public health crisis, which is always at our doorstep. They were appropriately in the field, leveraging existing investments to ensure long-term sustainability and critical infrastructure. The clawback of federal investment was unprecedented, as money previously obligated to local health departments had never been rescinded or clawed back without cause. There was no early notice nor consultation, and local health departments were left in a really disruptive state as a result of that clawback. It impacted health departments across the country. I'll give a few examples for you. In Kansas City, the health department lost funds in 3 major areas, including funding to upgrade the agency's laboratory, funding to buy additional COVID vaccine doses for people who couldn't afford to pay for them, and funding for 8 community health workers tasked with connecting vulnerable patient populations with preventive care services and other resources. In Missouri, in Jackson County, the health department immediately laid off employees who worked on monitoring communicable disease outbreaks in local schools. That capacity was gone. In Dallas County, more than 50 immunization clinics, many scheduled for schools in areas with low immunization rates and at risk for outbreaks, had to be canceled after the cuts. And in Utah, in Salt Lake County, 17 employees in epidemiology, nursing, and community health were laid off due to the cuts. In Bismarck-Burleigh County, North Dakota, they lost funds that were used for a 24/7, 365-day facility focused on crisis response, mental health, and addiction services in the community that reduced patients' reliance on emergency room visits. In many of our over 3,300 county and city health departments, construction projects were stopped that improved patient examination, waiting rooms, mobile health clinics were paused, servicing remote and economically disadvantaged areas. They were put on hiatus. Health educators and nurses working deep in community lost their jobs. And the impact was really swift and real and impactful and painful. While some states and locals received an injunction on the clawback, many did not, and creates an uneven and inequitable landscape across the country in terms of this work continuing or not. Similar impacts have occurred due to delays in funding being released from the federal government. For example, federal money to address the leading cause of premature death in this country, tobacco use, would typically have been released in the spring, And to date, those funds are still held up at HHS, but local programs have already had to stop. And the people who could have been helped by them must now wait. Looking forward, the administration has proposed significant reductions in federal public health funding and a large-scale reorganization of federal agencies and responsibilities that may signal even more drastic shifts in our important governmental public health system, local, state, and federal. That makes it harder to plan for and be proactive in addressing real public health challenges that we always face. Look, often change is needed and change is welcome. Now, I welcome intentional and good change that improves the lives of people and improves our processes and our systems. Change is not necessarily a bad thing, but it needs to be grounded with situational awareness and intention, and local health departments need to be at the table to help direct where that future of the field is going. And to date, that's just not happened. While it's outside the time frame of this report, it's important to note we've seen continued interest from both the House and the Senate to invest in the nation's health departments. And this is a really important and positive sign. We look forward to working with our colleagues here and with our federal policymakers towards restoring investments in public health that are sustained and predictable for the county and city health departments of our country and for the betterment of our entire federal government public health system, state, local, and federal. Thank you.
Thank you, Lori. We'll now move to the Q&A portion of our program. If you have a question, you're welcome to submit it through the Q&A function. We welcome your questions. Our first question is from the Alabama Political Reporter. I'll read it. Can you further describe the roles public health agencies such as CDC play in improving rural healthcare access and how the proposed cuts would hinder those goals? Dr. Cantor, I see you shaking your head, so we'll begin with you, please.
Sure. Thanks, Wesley. It's a really great question. Listen, protecting the health of rural Americans is so incredibly important and is particularly threatened by the instability of public health funding. First, to state the obvious, every threat that faces most communities in America faces rural communities as well. So foodborne illness, hospital-acquired infections, thousands of others, those threats are no less acute in rural communities, but the resources present to help protect against those are likely less robust. In rural communities, you might have a critical access hospital that lacks a full cohort of specialty services. They might lack a robust academic affiliation. They might rely more on the technical assistance and expertise of a state health department or directly with the CDC. They might be more isolated. So they might be better prepared to address some of the threats that are not unique across communities across the country. And there certainly are specific instances and specific examples where the threats are unique. A lack of transportation, geographic isolation, impaired access to care, food deserts, lack of adequate physicians, lack of specialties. All of those are really important issues that traditionally a local or a state health department will be working to address. Health departments oftentimes operate critical access clinics or public health clinics in rural communities where other access to care might be lacking. They assist with transportation services in many ways. They partner with local organizations to help extend care and bridge what might be an access to care gap or a coverage gap. These are really important activities that when the overall structure of public health is threatened, or even when it's just unpredictable and unstable, as has been the past few months, it becomes harder for health departments to work with local communities to address those issues. I'll tell you one of the lessons I've learned from responding to public health emergencies as a state and local health director, many more emergencies than I would care to go over, is that vulnerable people are vulnerable. And when you think about a particular community and what their vulnerability might be, it's not difficult to predict how they might be challenged during an emergency, whether that is a natural disaster or a self-inflicted emergency. Our rural communities are vulnerable, and instability in the public health infrastructure and the funding network that supports that will affect rural communities disproportionately.
Other panelists want to add anything about rural communities?
I would just add that, and that was a really thorough response. Thanks, Joe. That these rural communities represent a significant amount of the areas that health departments serve in the country. 60% of the health departments serve small, rural, frontier communities like this. And so they're really important to pay attention to, and they need as much attention as large and medium-sized communities, and often even more, because the problems are different in rural communities, and they're different in terms of accessibility to services, in terms of chronic disease prevalence, and in terms of provider availability and specialty services. So something really that needs to be watched at all times is ensuring that we don't leave additional gaps in our delivery of programs and services to those communities. And funding is always front and center because it takes more money to reach for communities often.
And I'll just add, and I think I'm just really underscoring, both Dr. Cantor and Lori's points here, is that role with regards to the federal agencies. And as we've been saying, there is the funding, but there's also the technical assistance that's provided, the guidance that's provided to help support health departments that work across the country, including in rural communities. And so the types of public health and prevention programs that can be tailored specifically to address these needs in rural areas, whether it's addressing the higher rates of chronic diseases or addressing injury and disability, having that guidance, that support and technical support is really critical, because when we know that there are also these barriers in terms of access to care, having healthier communities is really critical. And we, of course, need the access to care. We also want to assure that we have healthier communities. And that's where public health plays such a vital role in really advancing those evidence-based, proven prevention programs that work, and working in partnership with health departments that are serving rural communities. The loss of staff, the loss of the ability to put forward that type of evidence coming from federal agencies, including CDC, is a loss to the rural communities themselves.
Thank you. Our next question is from the Kentucky Lantern, has to do with some challenges that Kentucky faces, but many states faced, I would say most states face, and that is increasing rates of smoking, chronic illness, diabetes, cancer, etc., and extreme weather events. Can we talk about the role that public health plays in managing these events, and how the proposed cuts and current cuts are going to affect these programs? Lori, should we start with you, please?
Sure. So these chronic diseases are really at the heart of prevention and public health. And as I mentioned in my comments, it's really interesting statistic that 90% of that $4+ trillion investment in healthcare is spent managing chronic disease after it's been rooted in an individual and is impacting so many different aspects of their life. And so we have to flip the script on this, folks, and really get it right. In order to bring down overall healthcare costs, we have to invest in these things. Now, we have a challenge ahead of us to Sarah's point here, and that we're facing really significant threats to our ability to invest in chronic disease prevention with what's been happening these last few months. And we've seen really a desecration of the chronic disease area at the CDC. We've seen the offices of smoking and health disappear, both at the CDC and the FDA, to address that serious core public health condition. And we continue, to have to really fight to make the case for why we have to maintain these investments in chronic disease. It doesn't mean that we can't explore other areas that are being explored by this administration that are also looking at the impacts of other things on chronic disease, but we certainly can't let go of some of our core prevention work in these areas. And the public health departments of the country on the ground are very well equipped to address chronic disease at a population level. But these investments are seriously being threatened right at this moment, and not just investments. The actual expertise at the federal level that helps guide us in these areas is lost. And these are, when we think to the future about rebuilding what we've lost here, we're going to have to address both of those in this area in order to get at what this question is referring to. Like how can you keep at these significant community impacts and not let go of the progress that we've made, and prove the value of prevention, as Joe stated earlier, is really key for public health to be able to show that we need that back.
Please. Nadine, we've lost your.
Good. Mute, Nadine. There.
Can you all hear me now?
Now we can.
Okay, great. If I could also pick up, I appreciated what Lori just said, and where Sarah started with the high rates of smoking in her state, and this issue, for example, around smoking, and what has happened with the loss of all staff at the Office on Smoking and Health. Again, the concern around funding and also that expertise is understanding that that office plays a coordinating role, working across all of the states. And we are seeing progress with regards to smoking. We're at a 25-year low in terms of youth smoking. This is the power of public health, and to be able to prevent the illnesses and deaths that could result because of smoking. We don't want to stop those investments. We shouldn't stop those investments as a nation. And that expertise, the funding, and continuing to assure that we have the resources to address still the leading cause of preventable death in the nation is critical. And the issue is we also still have disparities as it relates to smoking. And so that kind of focused attention, focused intentional funding and support is really critical, so that we can continue to make progress, because that progress is fragile. It's fragile if you look at issues like smoking. It's fragile if you look at issues like our progress in overdose prevention. All of those issues, we have to assure that we have stable, predictable funding, as well as the expertise to support continuing that progress for years to come.
Thank you. Our next question is from State Line. It has to do with any actions that state legislatures have taken to fill the gaps that will be created, funding gaps that will be created because of the federal cutbacks. And I think to broaden the question a bit, will states be able to fill these gaps? Is it a reasonable expectations that states will be able to fill the funding gaps? Dr. Cantor, can you start us off?
Yeah, it's not. And states and territories can completely replace or fill these gaps. That's the bottom line. That there have been a few examples in the past few months, and going back before that too, where a particular program may have been cut, and state administration or state government was able to work with their legislature and replicate the funding. And I think, for folks that have watched that, they, were likely happy that the particular program was able to continue and that funding was found. But there's a real limit to how much that can happen. Again, your average state health department, we're talking, 65 to 85% of the operating dollars are coming federally. And, the balance of that is coming state, if that. So these are really hard budget gaps for a state legislature to compensate for, impossible to compensate for without warning. And the abruptness of some of the funding cuts, certainly the instability in which, grants being held back or not being paid out as congressionally appropriated, in many cases without warning, near impossible, for a state government to compensate for or replicate that. I would presume it's equally impossible for a local government to do the same. And I'll, extend that to philanthropy too. I think there's been a fair amount of conversation about the role of philanthropy and faith-based organizations, and they have an important role. And I had many productive partnerships with them, but there's not enough dollars in that arena either to compensate for that, let alone the lack of expertise and technical assistance. So I appreciate entities that have stepped up to help smooth over some of the fault lines now, but there's a real limit to how much that will be possible.
I'd love to hop in here real quick if I could, because that is absolutely all true. And I would add another important component of this, though, is, it's not just money we're talking about. We touched on the restructuring of the workforce and the people, and the people matter here a lot, because they are, it's not just money flowing, as part of this partnership, federal, state, and local, but expertise flows too. And there's expertise positioned at every level of this governmental public health system that is intentional, that's meant to support and balance the expertise at the other levels of the governmental public health system. And we lost a lot of that. And, so that's a sort of a double threat here with the funding. And, then there's other things that go with that as well. But locally, I think our best bet, is to, and we're starting to think this way, is, how are we going to define what is absolutely essential to have in place in a health department to ensure the safety and security and health of that community at the most basic level, and how do we tell people that that is what is necessary to continue to keep our country safe? And those gaps are being identified now, but there's no body and no entity that we know of that is able to easily step in the place. We have to do this together and figure it out.
Thank you. We have a lot of questions coming in, so I'm going to try to keep us moving. We have a question about the delivery of substance abuse services, substance misuse services in communities, and the fact that they are to a great degree supported by federal grants. So what is your concerns about what will happen to such services and the people who need them going forward? Nadine, Dr. Gracia, do you want to begin, please?
Sure. Well, I'll say that this is an example. Lori had alluded to it earlier, of what investments in public health and prevention can do. And this is not just 1 year investment. This has been over the course of recent years, investments as it relates to substance use prevention and treatment. One, it's understanding the important investments that have been made, for example, in overdose reversal medications and ensuring broader access to those medications. It's assuring that we're modernizing our data systems to be able to rapidly assess the changing and evolving drug supply. And that's where there's a lot of coordination, local, state, and federal with the CDC to better understand and get data faster, more real time, and to understand what the patterns are, and then to be able to identify where resources need to be targeted to help support communities that are being disproportionately impacted. It's assuring that there's outreach and education that is done, and having the workforce in place to be in community and reaching out to community, and assuring that it's meeting the needs of the populations that are being disproportionately impacted. We have been seeing just in these recent years declines in drug overdose deaths, and that is important progress. But as I mentioned earlier, that progress is fragile. If we don't sustain the investment, if we don't continue to modernize our data systems, if we don't continue to invest in these types of evidence-based programs and support, then we could see reversals. And that is truly tragic when we know that we have programs that work. And this has been across administrations that we have seen a clear understanding of the importance of addressing substance use and mental health and well-being.
Next question is about concerns that vaccine preventable illnesses will increase because of barriers to access, potential barriers to access to vaccination, vaccine availability. Dr. Cantor, do you want to begin with this question?
Yeah, I'd be happy to. It's a real concern of mine too, for a number of reasons. At the end of the day, I think what's most important to me and most other people is that families have options to do what's best for them, for their kids, to do what their doctor recommends. And when those options go away, it's highly concerning. I think if you talk to folks in health departments, both in the local and the state level right now, they would probably tell you that they've spent the past few weeks, the majority of each day, working towards preserving access to vaccine services in one way or another. That's important work, but I'll flag for you. It's somewhat, it's backtracking in a way, because every hour spent working to preserve access to vaccines is an hour that's not spent working to make the community more healthy, and to push health and wellness forward. So I'm very thankful to the efforts that are out there now to ensure that families across the country continue to have every option available to them. But I do think it's duplicative effort that, in a perfect world, could be redirected elsewhere.
Others?
Do you mind if I add just that, we've already seen immunization dollars sort of declining and changing and disappearing. And this is a huge consequences, of course, to communities that have made such progress. And we're talking about not insignificant numbers here in the communities that are well protected. 96% of people have agreed and accepted and gotten this vaccination. So, first and foremost, let's try to preserve that right of access for the people that really want it, so that we don't lose. As Joe said, we don't want to go backwards. The trending for public health is always in the direction of better outcomes. We made it. We made it, right? Largely in a lot of areas because of vaccine, in terms of measles, and polio and many other diseases. And so this backtracking feels like the worst possible thing that can happen for public health. And so, this access, even for the people who want it, is really important to maintain. We can always do better, and we will always understand we will need to do better educating and informing and helping people answer the questions that are hesitant about vaccines. That's not what this is. This is making sure that also the people that want it can get it, and that we maintain some of those communities that have succeeded. And we don't want to see disease enter their communities because they backtracked.
Next question is about,
if I could add to that, Rhea, just to
please.
say, when we talk about the importance of vaccines and vaccine saving lives, as Lori was just articulating, it's so important to understand that it's also, we're reducing suffering. Vaccines are saving lives. The suffering that children, families, communities will experience due to vaccine preventable diseases, and it's also cost effective. The return on investment on vaccines, it is far more cost effective to prevent these illnesses and deaths than it is to treat these illnesses that can be prevented, to have the hospitalizations that we see and the rising healthcare costs. Preventing measles, for example, rather than treating measles outbreak and having to deploy staff, perhaps even having to shift the priorities that they have to work on, sending staff from CDC to help support in the field. These are all expenses that we then have for something that is actually preventable. And we know that it's preventable and actually has helped us in terms of improving our health outcomes as a nation for more than a century.
Thank you. Our next question is about global public health, and will the current cuts and proposed cuts impact global public health, and should we be worried about that? Dr. Cantor, you want to begin?
Potentially, yeah, and I am concerned about that. One of the things that the CDC does really well which falls into the bucket of no one knowing about, is that they have a strong international presence and they work with many countries abroad, work with their national health agencies, and help stop outbreaks before they grow. It's much easier to stop an outbreak when it's small or limited to a particular region of one country than when it grows and crosses borders. And the CDC is so good at that. They're so good that very few people know about it because they have so many wins, so many examples of working with another country quietly in the background, effectively, and bringing an outbreak under control before it rises to the level of making headlines. I've been deeply thankful for that. As a health officer from a city that receives a lot of international travel, I've been deeply, deeply thankful for that work. I think that work is at jeopardy. We have this handicap in public health because oftentimes our greatest successes are secret or not known. And I think the CDC's international work falls into that bucket, but they perform incredibly important work that makes our country safer by controlling international outbreaks before they reach our border. And I very much want to see that work fully funded.
Laura, you have more?
I don't just want, we have to. In order to have full awareness and really have a good handle on surveillance of threats outside of our borders, we have to have that presence globally. And I don't think a good, and as Joe mentioned, I don't think a good enough job has been done really of highlighting the extent of that work and what it entails. But when you are in incident command mode and hearing about how diseases are tracked from the earliest stages and outbreaks are tracked and threats are assessed coming into our country, you have a new appreciation for that. And just to point out, in a mere, 7-9 months from now, we're going to be the site of the world's largest gathering for the FIFA World Cup. And preparedness is critical to this. And part of our preparedness positioning has to do with the ability to understand what threats are at our doorstep. Well, now we're going to have millions of threats inside of our doorstep on us in our house. And so right now, that preparedness stance and getting ready for that is critical. And that world of presence and knowledge and understanding of what's going on is crucial to getting ready for that arrival next year.
Dr. Rossi, anything else on this topic? One of my colleagues did note that CDC's global health budget for FY 26, the budget request, the president's budget request for FY 26, eliminates programs for global HIV/AIDS, tuberculosis, immunization programs in their entirety. So a very serious issue. We are about at time, so we're going to close out with a few housekeeping issues. One is that we will be first of all, I want to thank our presenters. It's been a really good discussion. We will be sharing the press kit and other briefing materials with registered media this afternoon. If any registered media would like to speak to any of our panelists, we'll try to arrange that. Send an email to TFAH, TFAH @burness.com. That's the same email address you used to register for today's event. And we'll try to set something up for you for an opportunity to speak to one of the panelists this afternoon. So again, I thank our panelists. I thank those who attended today. Thanks for your interest in our report. The report will be live on Thursday morning, overnight, Wednesday to Thursday. The embargo lifts at 12:01 a.m. tomorrow. Be live on the TFAH website. And just a reminder that the embargo is on, we are under embargo until 12:01 a.m. tomorrow. Thanks very much. Thanks for joining us.